case cubing. So we will do that. Okay. So let's get started, starting from the fatigue. So very, very important, your concept about fatigue, because it's also covered in psychiatry and also covered in clinical. So you need to know both of the approaches, how you are going to do, as not just in QE1, but also very important in NACOSCI. So your concepts about this should be very, very, very clear. Okay. As this is basically difficulty and inability to initiate activity, maintain activity, or difficult with the concentration. So, not just with the activity, but if the patient is coming to you with the concentration or memory issues, you can think of fatigue. But at the same time, fatigue should be separated from the burnout. Okay? Burnout is something different, but fatigue is something different. But it is mainly characterized in the same. But your concept should be very clear about that and what you are going to do for the patient of burnout. I don't think so it is mentioned in Toronto notes anywhere about the burnout, but at least Google a little bit about burnout, because that is also very quite important topic. Okay. So the patient's specific complaint can should be clarified, like excessive sleepiness and muscle weakness, exercise tolerance, and mood concern. See, there are few of the symptoms that is just like depression, but at the same time, in the depression, there should be the MSIGE caps. 5 of those symptoms should be there. Okay. So in this one, either one of these, like maybe excessive sleepiness, but not other symptoms are fulfilled, right? So on the basis of that, you can see this is not a depression, but fatigue. Okay. So make sure you know everything about it, because fatigue is one of the very, very important topic. So it starts at the 20 to 40. Female is more common than male, and 50% associated the psychological complaints. That's what I'm saying. Psychological complaints are basically 50%, especially if less than 6 month duration. So knowing about this is very important. Then coming to the differential diagnosis. So you need to know the differential diagnosis. The black ones are most common one. So at least if you cannot remember the like all of them, try to remember the common ones. As I told you, common ones more common. Don't forget them when you are doing uncommon ones. Okay. Starting from psychogenic, always rule out depression, life stressors, obstructive sleep apnea, sleep disorders, vascular infection, anemia, as they didn't mention which infection is more common. So any of the infection could be common. Okay. So talking about anemia, as always, rule out anemia. If you're suspecting something like this, even in depression, in something like that, or somebody who is having this kind of vague symptoms, try to rule out anemia. Okay. If they ask you to rule out one thing and you couldn't come up with anything, so try to think simple. Okay. Always the simple and the very clear answer is the specific answer for it. Okay. So moving on to which one? Drugs. So they didn't mention which drug, like is more common. So all of the drugs can cause it. Polypharmacy in adults, polypharmacy. Okay. Substance misuse. Always rule out substance misuse. Misuse. How is basically said as SAD: smoke, alcohol, and drugs. So these three things you should rule out. Then talking about hypothyroidism, you cannot miss out hypothyroidism. Diabetes mellitus, one of the very, very common thing. So always rule out. Then you have to start with the investigations, mostly psychosocial causes. So in the history, you will find out if the patient should need further investigations or not. But at the same time, if they mention the psychosocial causes, you can rule out anemia or something which is like potentially could be the cause, underlying cause. Okay. But at the same time, the investigations should be minimal, as less as possible. Okay. Then coming to the physical causes of the fatigue associated with the symptom signs that can be elicited from a focused history and physical exam. So according to the history and physical exam, you will get to know what is it. Then CBC, differentials, electrolyte, bijou and creatinine, ESR, glucose. So you have to rule out all the basic things. Then moving on to something which is basically ANA, beta HCG. Actually, beta HCG is the first thing if a female fertile woman is coming to you. Okay. Then Benz-Jones protein or all of those things. If you are thinking of multiple myeloma might be the cause, albumin might be the kidney, the issue, protein electrophoresis might be something underlying going on. But these are not the first line. Always think the potential causes, maybe iron deficiency, anemia, or something like that. Then beta HCG could be the potential first one. then glucose potentially first one, thyroid potentially first one. Then think of something which is basically underlying. Electrolytes could be the first line, right? So try to think the basic ones, then moving on to ALT, AST, if the patient is giving you the history, then otherwise you are not going to do those ones. Okay. The urine analysis, chest X-ray, ECG, serologies, Lyme disease, hepatitis B, C, HIV, ANA, and then Montauk skin testing. So which patient would be preferably done Montauk skin testing first line for them? Kindly write it down. I will tell you the answer. If a female is coming to you, she is complaining of fatigue, which potential female or male would be the one would get the Montauk skin testing as a first line? Then coming to the treat underlying cause, as always, you find out the cause, then you have to treat it. Starting with the reassurance, because the patient is panicking, might be some underlying pathology going on. So you're going to start with the reassurance. Then follow up, especially with the fatigue of the psychogenic etiology, then sportive counseling behavior and group therapy. Mostly this works out. There is one thing that you shouldn't miss when you are talking about the treatment of fatigue. If anybody knows, write it down, I will let you know. So immigrant coming from endemic area. No, a female who is indigenous female along with beta HCG, which are male, female or male, along with that indigenous, because in Canada indigenous is more common, and along with that, if there is not mentioning indigenous, immigrant also. Yes, so immigrant also, but indigenous. Okay, so my point of view, or where I was thinking was indigenous. If they mention indigenous, the first thing that you want to rule out is TB along with fatigue. Okay, so here the first thing, the most important thing in fatigue you are going to talk about is basically sleep. Maybe the sleep pattern is disturbed. So in the treatment of fatigue, which one thing along with reassurance, counseling, behavior, you cannot miss is sleep. Always talk about the sleep pattern or sleep hygiene or something like that to the patient to recover from fatigue. So which one thing you shouldn't miss in the treatment? Sleep. Okay. Then coming to the counseling, behavior, group therapy, encourage the patient to stay physically active, to minimize functions, consider using motivational interview techniques to create a personal centered approach. So you get to know what is the cause and treat according to that. Then along with all the medications, might be polypharmacy, she's taking too much medication, over the counter, herbal remedies, drug to drug interaction, and then after 1 year, prognosis. Chronic fatigue. Now this patient has a specific diagnostic criteria. It should be substantially reduction or impaired in the ability for at least more than 6 months, accompanied by fatigue of a new onset, not elevated by the rest, and not caused by the excessive exacerbation. Like it is there. She doesn't complain like I do some work and then it exaggerates, or I didn't do rest and then it exaggerates. It's just there and lasting for more than 6 months. So this comes in the substantial reduction or the impairment. Then coming to the post-exertional malaise and unrefreshing sleep and all of these things, this is too like deep of it. Just get to know a bit of it, and even writing chronic fatigue syndrome will be more than enough. If you know more, then yeah, very good. Okay. So cognitive impairment should be important. If you are ruling out fatigue, at least rule out cognitive. As I already told you, the patient could complain of concentration and memory. Okay. As usual, female is more than male. Unknown, like multifactorial, could be any cause. No specific diagnostic laboratory testing. So which one thing I mentioned to many people who like study, always rule out which specific conditions you don't have to do investigations. It would be very easy for you, because there are certain conditions that you don't do any investigation. I have been keep on mentioning, even in those investigations, you are not going to do even CBC, right? So if they ask you any investigation, sometimes they're just checking you if you even know or even not. Like you are just writing down CBC. I mean, definitely you want to rule out anemia or something. But if there is no specific investigation needed, they might think that you are just putting something as usual, like because you are not sure. So you might getting up getting like no mark for that. Okay, so no investigation. If they even writing down 3 lines, 4 lines, so if there is no investigation, the answer, you have to write down no investigation. You cannot write down in 1 line CBC and then and the second one no investigation needed. Okay, at the same time, you need to know where there is no investigation needed and where is the diagnostic of exclusion. That two are two different things. Where there is no specific diagnostic testing means like there is no investigations needed, right? But in the same time, if they say diagnosis of exclusion, then you at least have to write down which basic ones you want to do and to rule out. Okay. At the same time, they said diagnostic laboratory testing. If you want to rule out some other diseases, then you have to write down anemia or something. If they give you a scenario of fatigue, and they're asking you to write down 3 differential diagnoses, right? You write down anemia or fatigue or blah blah blah. Then moving on to the next question, they ask you write down investigation. Now you cannot write down no investigation needed because you are not sure that this is a fatigue, right? You didn't write down one diagnosis, but you write down 3 differential diagnoses. Now, moving on to the next step, you are going to do investigations, which will help you to rule out those for other two diagnoses to make your one diagnosis. Then your treatment should be based on your particular one. Okay. So promote sleep hygiene, as I already talked about. In fatigue, you are going to talk about sleep hygiene. Don't miss sleep. Along with sport, reassurance, the patient improve over time, physical activity, diet, psychotherapy, family therapy, sport groups. Then coming to the motivation interview techniques, to the person-centered approaches, relief symptoms, antidepressant, anxiolytic. So it might be needed whatever the underlying causes. So you are going to talk about that. So fatigue. The next one is sleep disorders. So the sleep disorder is one of the very, very important. Don't miss it just because they are not very important. Just like give it a good read so you know what kind of those ones are. So there are 3 complaints, basically insomnia, no sleep, parasomnia, or excessive daytime sleepiness. What is insomnia? Difficulty falling asleep, difficulty maintaining sleep. In this topic, I'll let you know what you need to focus on. Parasomnia, night terrors like nightmares, restless leg syndrome, somnambulism, then excessive daytime having abnormal fatigue or tiredness extending into waking hours. Now coming to etiology, if you know primary, secondary, then those are divided into further. And with that, you can see which are the medical conditions, which are the drug, which are psychiatry, and the lifestyle, like some shift worker or jet lag. Now, talking about the history, so you are going to be taking a very focused history to rule out all of these conditions. If they ask you to write down 3 lines or 4 lines, or what are you going to ask to that particular patient, your concept about primary and secondary should be very clear, since you are going to focus your history on the basis of those particular things. These two are important, primary and secondary. So your questions should be focused on the both of them. If you are not clear, is it primary or is it secondary? But at the same time, if you know this is primary, then your whole questions will be surrounding in regards of these primary insomnia, narcolepsy, obstructive sleep apnea, restless leg syndrome, or periodic limb movement. But if you are not sure, then you are going to rule out these ones along with these ones. So in 5, you have to smartly divide 2 or 3 over there and 2 or 3 here. Then moving on to the investigation, you are going to start with the complete sleep diary. Every morning for 1 to 2 weeks, remember this sleep diary, urine diary, or all of those diaries, they are menstrual diary, they are very time consuming. So wherever it's needed, there you are going to do. It's not like you are going to write down diary and somebody is going to start making diary. It's very time consuming. It needs a lot of potential. It needs to be accurate to make your diagnosis. So this sleep diary, wherever it is needed, you are going to do. Okay. So record bedtime, sleep latency, total sleep time, awakening, and the quality of sleep. So rule out other medical conditions along with it. Refer to the sleep study, nocturnal polysomnogram, then daytime, multiple sleep latency. So these things you have to rule out. Then starting from the management. So now primary is different and snoring is different. Starting with the primary, talking about all the daily life, non-invasive procedures, where you are going to talk about all the medical, psychiatry, if the patient is having nightmares, night terror. So you are going to talk about fear, anxiety around bedtime, what is the cause, right? Now talking about the sleep hygiene. Let's suppose if they ask you, what are you counsel the patient about sleep hygiene? What are you going to do is avoid alcohol, caffeine, nicotine. Use bed only for the sleeping purpose. Don't use bed for the other purpose. Like sleep environment should be comfortable. Regular sleep, no napping. So you are going to talk about these basic ones. Then relaxation, deep breathing, meditation, stimulus control, reassociation of the bedroom with the sleep. So consistent sleep wake schedule, reduce activities that cue staying awake. So all of these are going to be talked about it. So this is basically comes in sleep, no, sorry, first line CBT. All of these are part of CBT. If they ask you one question like how you are going to counsel or what are you going to tell the patient, so you are going to start with CBT, talking about the sleep hygiene, relaxation, stimulus control, sleep restriction, and address inappropriate beliefs, like maybe she has some sort of beliefs. So on the basis of their history, whatever they said in the history, maybe she's taking too much caffeine. So your treatment or counseling should be starting from whatever is told in the scenario. Then you are going to add whatever you want to write. Okay. So make sure you address whatever is written in scenario, because what they need is given in the scenario. Along with it, you can write whatever you want. Okay. Then coming to the pharmacological, short acting benzodiazepine, but in the very like uncontrolled or having a lot of problems when the patient wants some treatment or drugs, or they specifically ask you if one drug you want to write down, then you are going to write down. Don't write down the patient who's coming to you for the first time or second time with a lot of sleeping problem. You are not going to start with the medication. Always start with the CBT. As a family physician, you are liable for these kind of things. Then moving on to the medication. Non-benzodiazepine is basically Zepiclone, Zolpidem, so all of the Z drugs, Trazodone. If no progressive or the limited improvement pharmacotherapy, then consider referral. Now they said you can do referral. Okay, so they said you can do first line CBT. Now you can even give pharmacological. If this patient doesn't improve after doing all of this, now you're going to do referral. Okay. Coming to snoring. This is basically soft tissue vibration and all of this is written. So what could you find on the physical examination? Obesity. Don't forget obesity. If they ask one of the nasal problem, you want to rule out polyps. If they ask you write down 3 diagnoses or 3 differential diagnoses, you want to rule out obesity, nasal polyps, or any nasal trauma or any nasal deviation. Okay, even tonsillitis could be the problem. So you need to see in regards of that. Then coming to the investigation, what are the investigation? Nocturnal polysomnography or airway assessment. Then treatment, sleep on the side, weight loss. Talking about the weight loss, this is basically behavior changes. Then nasal dilators, tongue retractors, and more mandibular advancement devices. Then also talking about the risk of the developing OSA. Now talking about OSA. OSA is basically apnea, and some patient, what happens is apneic episodes can last from 20 seconds to 3 minutes, occurs like 100 to 600. Based on the nocturnal polysomnography for 15 to apneic or hypoapneic episodes per hour. So much that more than 15, okay? It should be more than 15. Then the consequence is very, very important. This hypertension, CAD, sometimes they give you the history of OSA and ask you to rule out this, or sometimes they give you this and then they ask you what are the risk factors. So OSA is linked with hypertension, CAD, and stroke, as it is 4 times increased with OSA. So don't forget this one, at least this one, this whole line. Okay. OSA is an independent risk factor for CAD. If somebody has OSA, could have CAD. Then hypertension and ventricular and core pulmonary. Then what are you going to do is obviously starting from the BP, inspect nose and oropharynx for the polyps, for that deviation. So these things for tonsils. Then blood gas is not helpful. So you are not going to do ABGs. ABGs are a very painful process. So you are not going to do ABGs. Okay. So you are going to rule out thyroid, might be macroglossia. Okay. So nocturnal polysomnography. Then treatment, modifiable factors first. What? Avoid sleeping supine, weight loss, avoid alcohol, sedatives, opioids, inhale corticosteroid, then primary treatment, and then you are going to do surgery. But primary is basically CPAP, maintain airway. Okay, and along with this, very, very important, this last line, you are going to tell the Ministry of Transport. So if they ask you, what are you going to do next? Since you have already done whatever you want, one thing that you shouldn't miss is report patient to Ministry of Transport. This is very, very important. Okay, now we will do some questions. Let's quickly do these questions. Okay, so the first question is 35-year-old woman undergoes elective termination of pregnancy at 12-week gestation. She develops fever, uterine tenderness, and is diagnosed with a septic abortion. Which of the following is the most common mechanism of her infection? Instrumental contamination, ascending infection, skin organism, urinary tract infection, or hematogenous infection? Kindly write down quickly so we can cover this one, because if the meeting stops, so we are going to stop. So somebody said E. So you said hematogenous infection. She has elective termination, and then she develops septic abortion. So somebody said instrumental contamination. So should I move on to the next one? Okay, so the answer to this one is B. What is B? Ascending infection. It's not instrumental, it's not hematogenous. She had done elective termination, which has developed fever, uterine tenderness, and is diagnosed with a septic abortion. Which of the following is the most likely mechanism? Is ascending infection, because of the all the tubes and everything that got it into it. So that's why the septic abortion is basically leading to ascending infection. Okay. So the next one is 30-year-old woman delivers a baby at the term that is found to be floppy and slightly growth restricted. During pregnancy, she suffered listlessness, poor tolerance to cold, and general lack of energy. Most appropriate diagnosis is anemia, gestational diabetes, hypothyroidism, pheochromocytoma, and Cushing disease. This is kind of easy. Everyone should write down the answer. So the mother was also having the thyroid problems. So now this patient, the baby, has hypothyroidism. So the answer is C, hypothyroidism. Good. So this question, this is basically a CDM question. I didn't give any options. So try to write down the answer. A 50-year-old man, try to participate. It's okay if you get it wrong. It's totally fine. It will just boost your confidence. A 50-year-old man presents in the ED with the blood and vomiting that started 1 hour ago, and now he is fine. He is known cirrhotic patient and had a esophageal varices, which were obviously banded like those varicose blend bending. Vitals now are little disturbed, but not much. But as his physical examination was started, he began vomiting again and tachycardia started. Suddenly, the mental status is also deteriorating. What will be the first step in the management? So just write down one. Anyone who is interested in writing this answer? It's a very interesting one. It's very easy. So this patient mental status is deteriorating. Okay, if you write down octreotide, you are killing the patient. And why are you transfusing blood? They didn't say that he has a anemia. So the first thing is intubation. Why intubation? Endoscopy could be the second one. First thing is the mental status is deteriorating, vomiting, tachycardia. So you want to save this patient. Either you want to protect his airway, writing the protection of airway, or writing of intubation. Because first thing first, A, B, C, everything comes second, third, fourth, whatever. He came ED, he was okay, and now he started developing vomiting, tachycardia, mental status is deteriorating. Maybe later on he went to coma. What are you going to do then? You have to put the patient to safe, then you can move on to the next. Okay, so airway comes first. Then moving on to the next one. This one is a little big. A 6-year-old boy with a history of asthma currently uses an albuterol inhaler as needed to manage symptoms of asthma. This is also a CDM question. His mother brings him into the office because she feels she has to increase the patient's use of his inhaler to 4 times per week for the past month. She also reports that she has woken up 3 times during the night from his symptom this month. The boy reports that he is upset because he can't always keep up with his friends in the playground. His past medical history is significant for allergic rhinitis. The patient temperature is 98 and blood pressure is 110/70. Pulse is 88, respiration is 18, with an oxygen saturation of 98 on the room air. Auscultation of his lungs reveals bilateral late expiratory wheeze. What changes could be made to his current asthma treatment regimen? Just one, just one, just one. And Dr. Mariam, try to write on the full and fledged answer, okay? So writing ICS is not an appropriate one, okay? Since your answer is correct, so try to write on the correct, the elaborated one, okay? So the answer is add steroid daily, okay? So either you can write down inhaled is more appropriate, okay? So if this patient also comes here, the same scenario, they might ask you, is it a mild, is it moderate, or is it severe? So they can also ask you this. Even if they ask you that, you have to label that this patient is mild, moderate, or persistent. Then moving on to the next one, they can ask you the next, in what is the regime you are going to add. Then also what could be the counseling you are going to tell the patient, okay? So this question could come in 3 ways. Asking about the diagnosis, what are you going to correct it? It's basically coming in family, so you are going to do it. Even when they're going home, what are you going to counsel the boy? And what are you going to counsel the family, like the mother or the parents, right? So you need to know all of the 3 things. Then moving on to the next, a 20-year-old man develops fatigue, fever, and sore throat. He has a swollen lymph nodes on the physical activities or exam. Rapid strep is negative. Which of the following is the most appropriate treatment? Admission to hospital, biopsy, sportive, antibiotics, and short course of steroid. Anybody interested in writing the answer for it? Exactly. This patient is having infected mononucleosis. So you are going to do is sportive, okay? Since he's 20, sore throat, everything is given, rapid strep is done negative, so and supportive, okay? So CDMs can come like this and CDMs can come right in. So you have to be practiced in both ways, okay? Then moving on to the next one. This one is also a CDM. A 24-year-old pregnant at 16-week gestation comes to you in October for her first prenatal visit. She has never had seasonal vaccine. Now they are giving you a hint in the scenario before. No past medical history. What is the next step or next thing you will give to the patient? So writing influenza is correct, but at the same time, you have to mention inactivated one. Because like tetanus, why are you giving tetanus? So writing down influenza vaccine is correct, but make sure you give your answer so perfect, you so accurate, the patient, the examiner knows what you are exactly talking about. You know, influenza patient, examiner knows you are talking about inactivated one, but why taking the risk, right? So why not just writing down inactivated influenza vaccination, okay? So try to be more correct one. Okay. I think that's it. No, actually one more. A 67-year-old woman is requesting that her immunization status be brought up to date. She received hepatitis A, hepatitis B vaccination, and herpes zoster 1 year ago. She get influenza annually. Next indicated vaccine is. So Dr. Nandini wrote pneumo. As I said, try to write on the full answer just to for your own convenience, because over there you will be like stuck with the pneumo, or like spelling mistakes or kind of those things will start happening. So try to just create the habit of writing full. Okay. So the answer is pneumococcal. If they ask me two, then obviously meningococcal also would be one of that. Okay. They have already mentioned that he has herpes zoster. So shingles and herpes zoster is same thing, right? So these are very like, I'm trying to like, these are the MCQs that I have collected from some different Q banks. So try to practice these kind of MCQs, because this is kind of MCQs that can be given in the exam, and do solve a lot of these. Even your way of writing should be very accurate. Whatever you are writing, try to be like, more expressive. So next person knows what you are writing and what exactly you are targeting at. Okay. So your answer shouldn't be vague. Your answer should be to the point, and you should be able to elaborate your thoughts to the patient, to the examiner in 1 or 2 words. Okay. So that's it for today. I think, yeah, I didn't make more than that. So try to like, do these kind of MCQs, because these kind of MCQs could be tested. It could be this much long. It could be very short. So, try to like do all of these. If anybody has any question. And tomorrow we will have our ASQ Bank session. I'm not sure when. I already mentioned.